We're good to go to start now.
Well, good afternoon. Welcome to Hypertrophic Cardiomyopathy Hot Topic Tuesdays, where we're going to talk about all various topics of HCM management. And we have a couple of experts with us to talk about each of these topics. The first one is today, Tuesday, October 18. I'm the moderator, Matt Martinez. I'm the director of the Hypertrophic Cardiomyopathy program at Atlantic Health System in Morristown Medical Center. And I am delighted to have two experts in the field, both multimodality imagers. Dr. Purvi Parwani comes to us from Loma Linda, California. She is an early career, but an expert already in the field. She is an emerging faculty member. We are excited to have Dr. Parwani. Welcome, Purvi.
Thank you.
And Dr. Kramer is the George Beller Lanthus Medical Imaging Distinguished Professor of Medicine. He's the chief at University of Virginia Cardiovascular Division. Those of you who know imaging know Chris from echo to MRI to various topics. He is clearly a leader in the field. We're excited to have you here. Welcome, Chris.
Thanks for having me.
So my job's easy. I'm just going to walk through some discussion about some complex discussions, I think, with regards to hypertrophic cardiomyopathy. This is an expansion of the program that we've had online the last year plus called Hypertrophic Cardiomyopathy Accelerating Guideline-Driven Care, and it's at Learn HCM. You can get there through acc.org as part of your membership. Dr. Steve Amon and I are both co-chairs of that, where we try and walk you through 9 steps of hypertrophic cardiomyopathy management and all of the pieces that go with care of your patients with hypertrophic cardiomyopathy. Now, we know this is common. You're clearly seeing this group, but if you look around the world, we're just not doing a fantastic job of identifying it. When we see LVH, given how common this is, we really ought to be thinking hypertrophic cardiomyopathy at top of mind, missing almost 90%, we think, worldwide of hypertrophic cardiomyopathy. So many times this is through a physical exam. It might be through a family screening of somebody who might have a family history of HCM or suspected family history of HCM, but often it's through imaging, abnormal echo, abnormal MRI in some cases, or certainly an abnormal ECG should point us down the discussion about whether or not this individual has HCM. So all of those pieces of the puzzle go in, the history, the physical exam, the electrocardiogram, does it all fit? But really imaging is the most important part. Echo, cardiac MRI, both really the mainstay with how we make the diagnosis of hypertrophic cardiomyopathy. And what we've learned over the last year or so and looking into how care is delivered for hypertrophic cardiomyopathy is that there's some common themes for missteps. We're going to try and go through those today during our webinar and ask our experts to help walk us through how to best identify and not participate in some of these missteps. Let's get started. So left ventricular hypertrophy, of course, is the hallmark of HCM, and accurate measurements of the wall thickness are critical. Dr. Kramer, get us started. How does it all start? You know, everybody gets an echo, right?
Indeed, everyone gets an echo, and here are some examples of echocardiograms from 3 different patients with different forms of HCM. So on the left, the top left, you have a patient with massive asymmetric septal hypertrophy in diastole. You see the septum measures well over 2 centimeters. In systole, you see the thickening of both the septum and the infralateral wall, as well as systolic anterior motion of that anterior leaf of the mitral valve. And this patient, in addition to the massive septal thickness, has SAM and LV outflow tract obstruction. We'll speak more to that in a few moments. In the top right, you have a patient with apical HCM, which can be missed by echo at times if the sonographer is off axis, or it can be overestimated by echo if the sonographer is off axis. So it's really important to get short axis images as well in the patient with suspected apical HCM. Ultrasound enhancing agents, as shown in the bottom right, can help the delineation of apical HCM and also patients with mid-cavity obstruction and apical aneurysm. We'll speak more to that later as well. So using ultrasound enhancing agents are often is often very important.
So diastolic wall thickness, right? That's the measurement timing. Any wall? Is there a specific wall or any wall thick enough? Anything over 15 millimeters, that's enough. Is that true?
Yeah, that's true. Any wall thickness more than 15 millimeters is diagnostic of HCM. Asymmetry is not necessary to make the diagnosis. And the other pearl is that if the patient has a documented mutation associated with HCM, that a wall thickness of 13 or 14 millimeters makes the diagnosis as well.
No doubt about it. So 15 millimeters in most. If you have a family history with a known gene, then thinner, 13, 14 millimeters can be enough. And you don't need obstruction and you don't need asymmetry. All the pearls of when to think about HCM. So where are the pitfalls? Where do we miss stuff? I'm going to go to the
Yeah,
next
go to
slide.
the next slide. Yeah, so there's problems with echo potentially with both over and underestimation, and we'll go through some of those. The biggest problem that we see is overestimation. When the sonographer, if you look at the measurement of the basal septum in the top left, you see that including the RV trabeculation is a major pitfall in overestimating septal thickness. And this is actually a patient from Dr. Martinez's laboratory, Echo Lab, where you can see that initial measurement includes this RV trabeculation and is over 1.5 centimeters. But when you exclude the RV trabeculation, it's only 11 millimeters. So the patient does not have HCM. They just have a prominent RV trabeculation. So the overdiagnosed, sometimes it can be tricky to really differentiate by echo, and you need to go to cardiac MR to make the differentiation to really accurately measure that basal septal thickness.
So this study sort of spoke to what you just said, right? MRI and echo both over and can over and underestimate wall thickness.
Absolutely. If you go to the next slide, this is data from a paper in Circulation Cardiovascular Imaging about 5 years ago, and the nice examples on the top left. You can see the patient A by cardiac MR, the true measurement of their septum, excluding the RV trabeculation, excluding also the LV trabeculation, is 1.7 centimeters. Echo, it's really less clear in the short axis. They're measuring 1.5, and in the parasternal long, including the RV trabeculation, they're measuring 2.2. So just within the same study, an example of under and overestimation. And then the patient B, who has an appropriate measure by CMR of 2.3 centimeters, you can see by echo it's overestimated again because they're including this prominent RV trabeculation measured by echo in the short axis at 2.9. In the parasternal long axis, underestimated at 2.0. And that bears out in the quantitative Bland-Altman limits of agreement analysis in the bottom right, showing that there's very little agreement. The scatter points are in both directions, over and underestimation. So CMR is really the gold standard. I mean, often with the good echo images and careful measurement, you can make the right measurement, but often CMR is needed to really be sure.
So truly multimodality imaging for HCM, right? They complement each other. They add different things along the way. And we're going to talk more about kind of what's added from one versus the other. So here is some MRI images from you, Chris, as well.
Yeah, so these are images taken from a study I'm co-principal investigator of, along with Stefan Neubauer at Oxford, called the Hypertrophic Cardiomyopathy Registry, which is a 44-site, 6-country registry of 2,750 patients with HCM that were in the follow-up phase, or over 5 years of follow-up now. And about 80% of patients, or a little over 80%, fell into these top two categories, A and B. A being isolated basal septal hypertrophy, where the only increased wall thickness is in the basal septum. That's about 40% of patients. And another 40% or so had this, what we call reverse septal curvature morphology, where the thickest portion of the septum is actually the mid-septum rather than the basal septum. Another 8% or so had apical HCM, which we've already discussed, was shown in patient C. Patient D has this concentric form of hypertrophy, and that was about 1% of patients. Patient E is a patient with a classic mid-cavity obstruction and apical aneurysm, and that was about 3% of patients. And we'll talk more about this as a high-risk subset. And then there are about 1% who fit in the other category. This is actually a patient of mine who has isolated lateral wall hypertrophy. So the asymmetry can be anywhere, and in this case, in the lateral wall. Next slide, please. So here's an example, again, of overestimation of the wall thickness. And you can see on the CMR, prominent crista supraventricularis, or retrabeculation, that's included in the measurement on the echo, because you can't see the differentiation, the blood pool between the two, the real LV wall and the crista. So this has important management implications, because, as you know, a wall thickness over 3 centimeters is an indication for an ICD in the most recent ACC/AHA guidelines. So by echo, you would have said this patient needs an ICD, but when you do the CMR, you say, well, hold the press. We need to fully evaluate the patient, look for other things to see if they have an indication for an ICD, because wall thickness alone does not make it.
So these are slides from Marty Marin from the Stop 3 on Learn HCM along our highway there. So more data and more sort of underscoring how valuable MRI can be in this condition, among others. So,
yeah, go ahead.
No, go, Chris.
Yeah, no, and we talked about that. It's important to make the measurement of maximal wall thickness wherever. It's not necessarily the septum. I showed you that previous patient where the lateral wall was the thickest area. So in terms of ICD indication, you're looking for any wall that's more than 3 centimeters. It doesn't have to be the septum.
So you gave us some great pearls about avoiding the RV structures most commonly, sometimes over measuring into the fringe with some of the ultrasound that can come through there just based on the technology itself, and having a low threshold for ultrasound enhanced imaging and or cardiac MRI. I think in our practice, we're doing both as part of our usual echo protocol. If we've not used contrast before, the sonographers pull the trigger very often, and cardiac MRI obviously plays an important part of our practice here, as I think it does for both of you.
Absolutely.
So you mentioned the MRI really shines over echo, but it's these 3 or 4 areas where those of you who are interpreting imaging and thinking about it, hypertrophy in the apex, the interventricular septum, those seem to be the ones, at least for me with athletes or for folks that are overcalled, that seems to be the area that is most missed, that anterolateral free wall, maybe up against the lung surfaces of the older individuals, and then that non-contiguous hypertrophy, right? Where you've got thickness next to normal thickness, whatever the sonographer he or she shows you, you sort of get. So there has to be some suspicion, and that's where, at least for me, the ultrasound enhancing agent really helps me stay out of trouble and missing increased wall thickness. So super review of LV wall thickness, probably the most important misstep we identify in this group, and required for the diagnosis. Of course, suspicion has to be high, but we're going to lead into now how we interpret ejection fractions, because this has been going on for years. This is not new. Dr. Parwani, help us understand the ejection fraction.
Thank you, Dr. Martinez. If we can go to next slide, please. Thank you. So if we look at the ACC/AHA HCM guidelines, we know that echo, is crucial for the diagnosis, but also for the ejection fraction assessment. So ACC/AHA gives it a class 1B indication to get the echo. And on the right side, we have a crystal clear image of how a parasternal long axis should look like. But we all know in clinical practice that that that's often not the case. Patients come in, in various size and shapes, and unfortunately, echo images can be challenging. So, along with that class 1 indication, as Dr. Martinez was just mentioning, ultrasound enhancing agents is a class 2A recommendation, and I think that we can extend it beyond LV thickness to the ejection fraction. And you may think that, well, the ejection fraction in these patients should be normal because typically they have hyperdynamic LV function. However, we all have to keep in mind that the ICD recommendation for these patients also include 50%, not 35%. So it's very important to give an accurate ejection fraction for these HCM patient because in the later stages, they do not stay hyperdynamic. Next slide, please.
Really important, right? The ejection fraction is critical. As the EF drops in HCM, they really don't tolerate it. And then some of these new medicines we'll talk about at the end, how critical the ejection fraction is for safety, for sure.
Correct. So in the next slide, so we all know that the efficacy and the time that requires for all these methods on the left side, and I may say that even if you are in a community practice, it's important to avoid that visual estimation of ejection fraction. 2D biplane, I would say that it's probably the most practical, even at different level of work that we do, even in a small community practice. So on the right side, you have a Simpson's assessment. Of course, there are other ways to assess LV ejection fraction, but a Simpson's method, a 2D biplane method, in my opinion, should be sufficient. And again, when the 2D pictures may not be sufficient to draw the LV endocardial border, it's important to utilize ultrasound enhancing agent. Next slide, please. And here is another example of how clear the CMR images look like. I often joke with my fellows that CMR is a very beautiful glorified echocardiogram. So remember that ACC/AHA guidelines, they recommend anytime the echocardiography is inconclusive, CMR imaging is class 1B indication. And similarly, not just for the ejection fraction assessment, but also for the wall thickness, apical aneurysm, and extent of LV fibrosis, CMR can be useful. So you remember to utilize the ultrasound enhancing agents as well as CMR in the cases where the 2D echo may not be sufficient.
So more data, right? More data about how powerful the echo and the MRI can be utilized together. As you mentioned, echo is often the mainstay for ejection fraction, but when in doubt, as it starts to drop, the MRI might be the gold standard, at least in our practice. And I'm curious, in yours and Dr. Kramer's, is everyone getting an echo and an MRI up front first visit, or are you more sparing than that?
Yeah, we're doing a CMR in every patient who's sent to us for evaluation of HCM, either before the first visit or right after the first visit. It's helpful in the first visit to have that data in hand.
I would say that in our practice we do a septal myectomy at Loma Linda, and initially it was not the practice for the surgeons particularly, but lately I've been seeing as the new guidelines have come out and we have done more multimodality imaging education, I get way more referral both from electrophysiology as well as from surgeons and interventional cardiologists to do these, particularly before they come for they go for septal reduction therapy.
Yeah, that makes sense. The surgeons can really have an idea where the touchdown is, how much wall thickness. That makes sense for sure. So let's get to the next critical misstep. I think maybe the most complicated of all of them, the LVOT signal, how we identify it, how you measure it. And then as part of that, we'll do a double here to identify the utility of stress echo in this individual disease, really important for HCM. Chris, get us started with LVOT obstruction.
Yeah, I showed an example earlier of the systolic anterior motion. On the top left, you see a different patient here, and you see the anterior leaflet of the mitral valve abutting the septum. It's complex what the chicken and egg is in terms of what leads to SAM and outflow tract obstruction. If you look at autopsy studies of patients with HCM, it's an endocardial disease as well, and the mitral valve is elongated, the cords are elongated, and that's part and parcel of it. But as well, because of the thickened septum, there's accelerated velocity along turbulent flow along the septum that pulls the cords and anterior leaflet of the mitral valve towards the septum. So it's a combined problem, and you can see on the M mode at the top right here the anterior leaflet of the mitral valve abutting the septum. Classic M mode demonstration of SAM. So the LVOT is narrowed by the combination of SAM and accelerated flow and pulling the anterior leaflet and the cords towards the septum. And that leads to obstruction of the LVOT. It's dynamic. It can depend on preload and afterload. You see premature closure of the aortic valve, and we'll talk more about the SAM leading to mitral regurgitation as well due to poor coaptation.
This is, as we all know, really a disease of obstruction, right?
Yeah, but again, not every patient with HCM is obstructive. In fact, 30% of patients are non-obstructive. So, and the other important issue is that you need to try to provoke obstruction at the time of your echo, either with a Valsalva or stress or both. And you can see that rest obstruction is present in about 37% of patients, but provocable obstruction, in this case exercise, leads to a diagnosis of obstruction in another 33%, leading to the total incidence of obstruction of 70% in all comers with HCM.
All right, so how do we figure this out? This is a complicated answer for echo and LVOT obstruction. So what are you showing us here?
Yeah, so you're seeing a patient who has the classic V sign, okay, where because of the SAM, in systole, they have turbulence in the LV outflow tract as the movie plays, as concomitant with simultaneous mitral regurgitation. So as the anterior leaflet's pulled to the septum, the outflow tract obstruction occurs. There's poor coaptation at end systole, and there's a posteriorly directed jet of mitral regurgitation. So the so-called V sign of obstruction and MR at the same time.
This is just a short axis view showing the same, right? Mid anterior leaflet of the septum being pushed in or pulled into the septum. Not always as easy to see on a short axis view though, huh?
Yeah, the parasternal long is the best view to see it.
Agreed. So walk us through this.
Yeah, so how do you define obstruction? We define it as a gradient of more than 30 millimeters of mercury at rest, or more than 50 millimeters of mercury with Valsalva or exercise provocation. How do we measure it? First, we use Doppler, pulse wave Doppler along the septum to identify the location of the obstruction. Usually is in the LVOT, but not always, sometimes the mid cavity. And then once you've identified the location of the highest velocity, then you use continuous wave Doppler, generally from apical windows, to ascertain the peak gradient. And we'll show some examples of the classic dagger-shaped envelope from continuous wave Doppler. And then you want to make the same measurements with Valsalva and or exercise. And the important thing, and we'll review this in a subsequent slide, is that there's often can be overlap between mitral regurgitation and the gradient from outflow obstruction, and it's incumbent upon a careful sonographer to differentiate those two.
So this is an example of where echo shines over MRI, right? Where the LVOT obstruction is really best served by echo. Again, that multimodality part.
Yeah, we can certainly measure a rest gradient by cardiac MR. It's modestly accurate, but it's very hard to do Valsalva, and certainly exercise in the scanner is not a trivial pursuit. So generally, the gradients are better measured by echocardiography. And again, as you mentioned, the complementary nature of this multimodality imaging with both echo and CMR in this disease. So here's an example of continuous wave Doppler in the classic late peaking dagger-shaped envelope in HCM. And this is a patient at rest. And then I think here's an example of a patient with a higher gradient with Valsalva or exercise, I'm not sure which here, but you can see that the gradient has increased well over nearly 4.5 meters here at peak provocation. So identification of obstruction with provocation.
So this shows also on those arrows, right? You nicely point out that mid kind of step off, right? Where the other one has that tapered look, where sometimes the LVOT gradient is more of that step off right there in the middle.
Yep.
So help us with these. This is where it gets complicated.
Yeah, so here's another example of a patient who has a gradient at rest of about 50 millimeters of mercury, so meets the diagnosis of obstruction. But then with Valsalva, you can see this late peaking gradient. Now it's up to 76 millimeters of mercury. And the same patient, if you move the Doppler signal to the our right into the left atrium, you're going to pick up this mitral regurgitation envelope. But you can see it's a very different shape. It's this rounded holosystolic envelope, classic for MR. So you should be able to differentiate that round appearance of the MR envelope from the dagger-shaped peak of obstruction.
So this is from Stop 3 as well, as really highlights what Dr. Kramer was just pointing out, how this is from Jeff Geski's lecture in Stop 3. As you mentioned, MR into LVOT gradient. You want to, any other pearls on this, Chris?
No, it's important for your sonographer to do a sweep of the left atrium, basically, from the center of the left atrium across and into where they're just in the LV outflow tract. And that helps you differentiate the MR here. And this could be confusing. You might say, oh, well, that's the late peaking. No, it's really the MR envelope. But as you move into the LVOT, then you get the more classic late peaking dagger. And then you really know that the LVOT gradient here is 4 meters or a little over 4 meters and not 8 meters. That's suggested if you look at the MR envelope on the far left.
So this is critical as we talk about at the end here for some of the new therapies, the ejection fraction, the LVOT gradient, distinguishing what you're absolutely treating so that not only you give them the right therapy, but you're following their success, right? If they're on a therapy, you want to monitor the reduction in LVOT gradient. Even if it's a surgical reduction, you'd want to make sure that post-surgery this was done, right?
Yep.
So here's a different example of MR with what I think is a mid-cavitary obstruction, Chris.
Yeah, so here you have you can see that the pulse here is not in the outflow tract at all. It's really through the center of the LV and into the left atrium. And so you have the late peaking envelope here, and in later systole, that's the mid cavity obstruction, and then you're seeing a piece of the MR, that's the higher velocity jet to the left of it, closer to the QRS.
So this is important. We talked earlier about ejection fractions. Most or many of the HCM patients have EFs in the 75 to 80% range. The whole ventricle collapses during systole, and you'll often see this mid-cavitary obstruction. Our echo lab reports all of it. They report the resting, the mid-cavitary, and then any dynamic obstruction after Valsalva, which is sort of the norm in our lab as we sort out HCM on a regular basis. But it's not always this easy, right? Sometimes they have symptoms and it sounds like obstruction. And hopefully on physical exam, maybe you brought out the obstruction with Valsalva or with a squat to stand maneuver. I have two flights of stairs right next to where my office is. I often will walk them up and down those stairs. I tell them this is the poor man's stress test. I listen to them before and after the two sets of stairs. But predictably or in practice, we need something else. And that's where stress echo comes in. Dr. Parwani, how are you using stress echo?
Thank you, Dr. Martinez. So I think Dr. Kramer and you put out a nice layout. So if we look at the guidelines for symptomatic patients particularly, who do not have resting or provocable outflow gradient more than 50 millimeters of mercury on Valsalva, exercise stress test is recommended for detection. And this is a class 1B recommendation. And even when we look at the asymptomatic patients who do not have the gradient, again, exercise stress test is recommended with a class of recommendation 2A. So I think that if you look on the right side, this diagram kind of shows you take a symptomatic HCM patients, you do their LVOT gradient at rest and with provocation. I haven't seen amyl nitrate being used these days in many labs, but mostly with Valsalva and squat to stand. And if that gradient remains less than 50 meters of mercury, you do exercise stress test and then figure out where the gradient is going. Now, if the gradient is less than 50, remains less than 50, even on exercise stress test, that patient, remains non-obstructive HCM, and then we'll do the repeat imaging in 1 to 2 years. However, if the gradient goes more than 50 millimeters of mercury, that patient deserves therapy. And if they are on maximally managed and already on medical therapy, then of course that's the cutoff that is considered for the septal reduction therapy. So I think the next slide will show us more on this. Yes. So if we look at the stress echo, there can be different ways we can do stress echo, but it's important that when the patient is doing that stress echocardiogram at rest, even when we haven't reached the peak, so kind of stage 1 at peak and even at recovery, to do the full assessment of not only LV function, but also, MR gradient, Valsalva, LVOT gradient, the RV function, what does the diastology look like? Because ultimately what we want to understand is why that patient has symptoms. So it's important to do the numbers both for MR and LVOT as well as LV function at different stages. On the right side, you have a flow diagram kind of showing you how this helps us in the management of this patient. So on the right side, if you have a provocable patients who has obstruction now and they're drug refractory, as I said, they get the referral for the septal reduction therapy. If they are mildly symptomatic and you have a gradient in that range, you would do the medical therapy. And if they are asymptomatic, as I mentioned, they will qualify for surveillance of 1 to 2 years imaging follow-up. If they remain non-obstructive, similarly, you will try to see what NYHA class they belong to, depending on this exercise stress test and their symptoms, and decide what can be the best management for that patient. Next slide. So this is an example I have for a stress echo utilization in HCM patients. So I think the rest imaging now, you can see that there is very mild SEM and mild LVOT obstruction, a really minimal or trace MR. And on the stress on the right side, you can see the heart rate jumps from 53 on the right side is indicated at 72. This is because we do treadmill exercise stress echo, and by the time patients come back and you start scanning, the heart rate may fall, but immediately post-exercise, the SEM does become prominent, and you can see that on the exercise on the right side, there is very prominent SEM, there is prominent mitral regurgitation, moderate to severe going into the left atrium. And on the next slides, I have gradient for this patient. Exercise echo is on the right side, the rest echo is on the left side. So again, I'm kind of showing you by arrow where exactly that mild SAM is happening. In image B on the left side, you can see very mild SAM. On the in image C, you can see that trace MR LVOT gradient at rest. The LVOT gradient is 2 meters per second with peak gradient of 16. On the right side, I show you what the MR looks like for this patient, as well as what the LVOT, gradient looks like on the right side. Now, it's important to keep in mind anytime you have gradient of or the velocity of more than 5.5 for LVOT, just rethink, and caution is advised even in every guideline statement that you look at. Always utilize the blood pressure for the measurement of LVOT gradient. Remember that even if you don't get a very clean LVOT gradient and it's contaminated with mitral regurgitation, you can utilize blood pressure to your advantage. So here I have given you the kind of the calculation how to do that. So using an MR gradient, you can figure out what the LV systolic pressure can be, because estimated left atrial pressure in most of the patients probably would be 10 to 15 millimeters of mercury. And now you take that LVOT velocity that you may have and figure out what the LV systolic pressure can be. And based on the blood pressure, you can correlate those two numbers. And if those two numbers match, then you are in the same range of LVOT gradient that you are looking at. So Dr. Martinez and Dr. Kramer, do you guys utilize this method to kind of correlate with blood pressure, what the numbers can be to accurately assess the patient?
Yeah, I think on occasion you need to do it when you can't measure the gradient accurately. Typically we can get an accurate gradient, but once in a while you need to use this method to estimate it.
Yeah, we teach the fellows this as a nice cheat, right? You can add on to it, make sure that if you're not sure if the gradient's really high, it can help you correlate if you go right into the MR signal and then verify that at least you're on the same path. This is hard. You've made this look really easy, but obtaining an echo stress for this is difficult. We have just a few sonographers that utilize this. Do you have a core group that you help kind of cultivate in your lab, Purvi?
Yes, we do have some sonographers who are very, experienced and advanced that do these difficult HCM cases. And you're absolutely right. These are, these are difficult echoes. And these are the echoes where you want to review as echocardiographer what the sonographer has done. Make sure that if needed, you scan the patient yourself and figure out what exactly the gradient may be. Because remember, now with new medical management, this is the key. You want to monitor your patient on how this gradient is coming down, etc. So don't be shy of using your hands on the machine if you need to. And for the for the fellows in the audience, this is a very frequently asked board question. So keep this equation in mind.
At least here, I'm often in the stress lab with them. Sometimes it's nice to see the SAM yourself. Tuesday's my stress echo day. I have one in another hour. So this is on my mind. The fellows like to look at the physiology is just superb. So that's awesome. So the obstruction is key, identifying it with either resting, Valsalva, and or exercise echo to look for obstruction, as this is an important part of management of HCM. Now, Chris, we've touched on it a whole bunch of times, right? MRI is really powerful. You and Purvi are both experts in this field. Walk us through some of these slides about the utility of MRI.
So yeah, first of all, late gadolinium enhancement is incredibly important to identify in patients with HCM. It occurs somewhere between 50 and 60% of patients with HCM. There's any LGE, and it comes in all sizes, shapes, and flavors. So the corollary is 40 to 50% have none, but then you see these 6 patients with very different forms of LGE, from confluent subepicardial LGE to the classic RV insertion subepicardial LGE shown in patient B. So all kinds of shapes and flavors. So this is a study, a meta-analysis of over 3,000 patients published in JACC Imaging in 2016. looking at the presence of LGE as a marker for adverse outcome. Again, it occurs in over half the patients, so we can't use the presence of LGE as an indication for an ICD because the incidence of sudden cardiac death in HCM is only 0.6% per year. So if you put ICDs in half of the patients, you'd be putting in way too many ICDs in this population. So in this meta-analysis, the presence of LGE was associated with a 1.8-fold increase in all-cause mortality, a nearly 3-fold increase in cardiac death, a 3.4-fold increase in sudden cardiac death or aborted sudden cardiac death, and a 2.2-fold increase in heart failure death. So yes, the presence is important, but we need to go beyond the presence. And if you go to the next slide. And this is a study from Marty Marin, and actually these patients made up part of the cohort in the prior meta-analysis. So this is the Chan paper, Circulation 2014. Marty Marin is the senior author, over 1,100 or 1,200 patients from 4 centers, followed over 5 to 6 years. You can see that this is on the y-axis, freedom from sudden cardiac deaths, and you're looking at LGE as a percentage of the left ventricular mass. So not just the presence, but the extent of LGE. So in the 3 top bars, you can see that it's about 1% per year incidence of sudden cardiac death or less. When you get over 15% LGE and over 20%, that jumps to 2% per year. And the bottom graph shows the number of sudden cardiac death events stepwise increases from no LGE to more than 10% LGE to 10 to 20% LGE to more than 20% LGE. So clearly the amount matters. The percent of LV mass that's obtended by LGE is a marker for malignant ventricular arrhythmias and sudden cardiac death. Next slide. And so in Wang's meta-analysis, when they looked at the extent of LGE, combining the Chan paper and others, that there was important increase per 10% LGE, all-cause mortality increases by 1.3-fold, cardio CV mortality 1.6-fold, heart failure death 1.6-fold, and sudden cardiac death 1.6-fold. So it's a strong prognostic marker not only of sudden cardiac death, but also heart failure events. The other issue that one must grapple with in HCM, and I mentioned that 3% of patients have this mid-cavity obstruction subtype with an apical aneurysm. And you see that the LGE is very important here to help delineate the apical aneurysm. These patients with apical aneurysm all have generally transmural LGE of this aneurysm, and quite frequently you find a LV thrombus in these patients. These patients are at high risk for ventricular arrhythmias, sudden cardiac death, and in the latest guidelines this is an indication for an ICD, and the next slide will show why that is. So this is a study from Rowan and colleagues and Jack a few years ago, showing that in the patients with an LV apical aneurysm, a 3-fold increase in HCM-related adverse events, and most of those were sudden death events. And so this is clearly a risk factor it's like having an apical infarct, essentially, and it's a risk factor for reentrant ventricular arrhythmias and sudden cardiac death. And you can see this is the algorithm from the latest guidelines, Steve Alman and all at Jack in 2020. So extensive LGE on CMR, more than 15%, is a 2B indication for an ICD. If you look up higher, the mid-cavity obstruction with apical aneurysm is a 2A indication for an ICD. Often the extensive LGE may come along with one of the other risk factors and help you in decision making. But if you have a patient that is sort of on the border and you see extensive LGE, that should push you to the err on the side of implantation. Next slide, please. So how did we go beyond LGE? So LGE is a marker of replacement fibrosis. You see late gadolinium enhancement because of delayed washout from collagenous scar, as well as increased volume of distribution. But there's another type of fibrosis that we can measure with CMR called interstitial fibrosis. So let me guide you through this concept. So this is from Eric Shelbert's review in JACC a few years ago, a nice cartoon. There's a normal patient in the top row and a patient with whatever kind, we'll say HCM. Patient has extensive interstitial fibrosis in the bottom row, but it can be other diseases as well, hypertensive heart disease, for example. So in the normal individual, you see the blood pool in the myocardium. There's a little bit of blue interstitial collagen. And when you give gadolinium, an image, say 10 to 15 minutes later, you see there's a little bit of gadolinium left in the normal individual. Contrast that to the patient with extensive interstitial fibrosis, such as HCM. 10 to 15 minutes after infusing gadolinium, you see a lot more gadolinium because, again, of the increased volume of distribution in this collagenous scar. Gadolinium is an agent that shortens the T1 of the myocardium. So if you perform T1 mapping, you'll see that the T1 in this patient will be lower than in the T1 of this patient. And one can use the T1 of the myocardium and the blood pool before and after contrast to measure what we call the extracellular volume. So that's the volume of the myocardium that's subtended by extracellular space. In URI, that's 25%. We'll talk in a moment of what that is in HCM. Next slide, please. So one can measure T1 before contrast as well. And this is the data from the Oxford group showing that even without giving contrast, gadolinium contrast, that HCM segments without late gadolinium enhancement have a statistically higher T1 than normal segments, although there's a lot of overlap. But segments that subsequently are shown to have LGE, there's even higher T1, again, because there's not only interstitial fibrosis, but replacement fibrosis in those segments. Next slide, please. And then the group from the Brigham have shown that measuring extracellular volume, remember I said controls have an ECV of around 25%. In phenotype negative, genotype positive, the extracellular volume in HCM is as high as 30% and maybe as high as 35% in phenotypically positive HCM. Although I will say in the HCMR study, the mean extracellular, I think this is a bit of a referral bias in this study. Our mean ECV in HCMR was around 30%, not 35%, but certainly elevated over control. And we're going to learn what the prognostic importance of interstitial fibrosis is as we follow patients in the HCMR study. And here's our summary slide from the HCMR study that was published in JACC in 2019 from the baseline data. And again, we're at 5 years of follow-up and hope to complete the follow-up phase within the next year and report it out in terms of improving risk prediction in HCM. In this baseline study, 2,755 patients, about 40% of them were sarcomere mutation positive. And these were the patients who had generally this reverse septal curvature morphology. They were the patients with extensive late gadolinium enhancement and higher T1 and ECV. And interestingly, because their hypertrophy is more in the midseptum, less in the basal septum, they had little to no LVOT obstruction. Another 40% or so of patients were sarcomere mutation negative. They had isolated basal septal morphology rather than the reverse septal curvature morphology. And they had little to no LGE and a lower extracellular volume. And because their hypertrophy is in the basal septum, they have more LVOT obstruction. So food for thought, if we were to hypothesize what our follow-up is going to show in HCMR, we would expect that it's the patients on the left with a sarcomere mutation and LGE that are at risk for sudden cardiac death, and it's the patients on the right with basal septal hypertrophy, no LGE, that are at risk for heart failure and LVOT obstruction and those kinds of events. So we'll see what follow-up shows. That's our hypothesis. Watch this space.
So this is going to be really important data, all of those pieces for MRI. I'll ask both of you, one of the challenges I think we all grapple with is distinguishing HCM from hypertensive heart disease. Are there specific parameters on CMR that either of you use to try and elucidate that complicated answer?
Yeah, I will see. We put everything into the equation. You have to look at the patient's history, first of all, right? Are they 7 years old and they've had severe hypertension for 50 years? And can they really, to get to a wall thickness of more than 15 millimeters with hypertension, you have to have big, bad hypertension for a long time. So you're not going to see hypertensive wall thickness of more than 15 in a 35-year-old. I'll say there's one exception to that. Maybe a patient with end-stage renal disease from their hypertension. So really bad hypertension. I think, if you have to get to LV wall thickness more than 15 in concentric from hypertension, you have to have long-standing severe hypertension, not you're on one drug for 5 years. So I think the clinical history can inform you to a great extent because there's no easy imaging way to differentiate the two. Certainly, if you have a genetic a mutation associated with HCM, that makes it easy, but often the concentric ones don't.
Agreed.
I
Perfect.
would add, yes, thank you. I would add to that, definitely, this is not just a challenge on CMR. Even I read so many echoes, and everyday echo, you look at septum and you think about HCM, it's important to look into the chart beyond that. I know that we all can be busy. Look at the chart, look at how many medicines the patient is on, what the history. There are examples where I have called the patient because there is no history listed, and I want to ask them about their family history so that I can make the right call. So I think history, as Dr. Kramer was mentioning, is very important. Also remember that with advanced hypertensive heart disease, there may be concentric hypertrophy. It's rare to have that thickness, but you also would see advanced diastolic dysfunction. So keep that in mind. On hypertensive heart disease, you can see some patchy LGE, but it may not be in the areas of maximal thickness. So that's another trick. And ECV predominantly in hypertensive heart disease, I would say, mostly the LGE won't be there. In ECV, the extracellular volume number would be normal versus, it's in some patients you can see both. But again, that's like very advanced hypertensive heart disease where you would see, both patchy LGE and increase in ECV. So I think kind of utilizing all the tools that we have is very important.
Yeah, I love it. So, that's what we started with, right? History, physical, the ECG, integrating all of those pieces into the puzzle and then having the imaging guide you. The question from the audience is really great because I think we struggle with hypertensive heart disease and then amyloid. And what about, Fabry? There's a whole bunch of other things that can cause this. But you see, HCM is so common that often we err on the side of caution. So, sometimes time is your benefit, right? So when do you repeat the imaging? Perfect. How often are you doing imaging over and over?
Yeah, those are great questions. So, of course, I have a guideline slide first. So, on the left side are the guidelines for the transthoracic echocardiogram. And again, depending on how your patient is doing, you can utilize imaging to your advantage. So, as we saw initially, those asymptomatic patients that remain asymptomatic, your exercise echo doesn't show much, you don't have that much of a gradient and patients are doing okay, then, of course, you want to do surveillance follow-up, and you can do it with transthoracic echocardiogram, and there the recommendation is 1 to 2 years. So in a stable patient, you can repeat an echo every 1 to 2 years, assess everything again on a follow-up echo. If you look at the patients who are symptomatic, so you have put them on medical therapy or they are not on medical therapy, but before they were stable and now they are not doing so well, do the TTE. And again, that's a class 1B indication. So use imaging to your advantage. And once the patient has undergone alcohol septal ablation or myectomy, septal reduction therapy, then the recommendations for follow-up on transthoracic echo is 3 to 6 months after the procedure and thereafter. If we look at the cardiac magnetic resonance, the CMR guidelines, again, if you have a negative CMR and patient is stable and you want to see, you have done that first CMR in a HCM patient where there is no LGE, but you want to see if they develop fibrosis over time, the recommendation there for follow-up is 3 to 5 years, and it's a class 2B recommendation. And remember, again, follow-up CMR not only shows you the thickness changes or the fibrosis changes, but also if there is any LV aneurysm that may develop in the mid ventricular HCM. So keep those follow-up numbers in mind. I think I have one more slide after this.
I think that's it.
Okay.
Matt, if
So
I could make one comment about you mentioned amyloid and Fabry. So one of the again powerful uses of T1 mapping and measurement of ECV in the differential diagnosis is that Fabry has classically very low ECV, and amyloid classically is very high, the highest ECV you'll ever, and T1, native T1 that you'll measure. So the ECV is often into the 40s and 50s, so which is very rare in HCM. So I think you can use ECV in many patients to make the differential between Anderson Fabry and amyloid and true HCM.
agreed.
I think I had this slide, Dr. Martinez. I was going to say, Dr. Kramer, those are great points. In my opinion, in a patient with LVH and who are very symptomatic and no diagnosis can be made, and everyone is putting it on hypertension and patient is not on that many antihypertensive medicines, I think use of advanced imaging, probably CMR, to figure out where that patient fits into that spectrum is very, very important to give that patient the maximum advantage. So this is a slide. I think if we go forward, then all the, yes. So this is a slide for mavacamten clinic. So this is a new medicine. I'm not sure in audience how many people are utilizing it, but one of the bigger challenges is how do we do the follow-up for mavacamten patients who are on mavacamten. So again, if we look at the recommendations that are made for this medicine, you're going to do the repeat imaging after you start the medicine. You're going to have a baseline imaging. You're going to do an echo, stress echo symptoms. You start the patient on 5 milligrams daily medicine, and then you're going to repeat the imaging at 4, 8, and 12 weeks. And this is not only to continue the medicine, but also to advance the therapy. And why this is important is because we are afraid of, LV ejection fraction changes on the medicine. And currently, at least the recommendations are due, every month or 4, 8, and 12 weeks. And once you establish that patient is stable on the medication, then for thereon, you will do it every 12 weeks or every 3 months. I know, Dr. Martinez, you have several patients on mavacamten. I was telling you, we have this challenge of who is going to follow up these patients, etc. So would love for you to chime in.
Well, this is the challenge, right? So I think today's discussion about ejection fraction quality and how we measure it and LVOT assessment, I think is now being really brought to the top as we look at cardiac myosin inhibitors in total, specifically mavacamten. And what we are doing is that we're doing it really as part of a big care team. And thank goodness we have good nurses, we have good nurse practitioners, the sonographers are good. They help keep this moving along because the symptom follow-up, the medication drug interactions, this is challenging. And I think HCM has always been a team sport. I think it's always been the ability of a clinic. The best programs I think in the country are doing this as part of a team. I think mavacamten and really all of cardiac myosin inhibitor drug therapy is bringing that team right to the front and moving things along. So that's how we're doing it. We're still learning more about this. We're enrolling in both the clinical trials as well as in the patient clinical assessment and following them. And we're excited about all the focus on HCM and the drug therapy that's coming to fruition. And I want to thank both of you for joining us today. Thank the audience for joining us today. We have time for just another question or so. There's a whole bunch coming through. I'll encourage you to go to Learn HCM, where much of the discussion there is amplified, and we can talk more about it. Chris, specifically, another question about T1 mapping. Are you using an ROI in just the septum, the entire myocardium? And then are you excluding areas of leak GAD? How are you doing that?
Yeah, and the answer is yes. Generally, measurement in the mid septum is probably the first step, avoiding areas of LGE because you're really looking for interstitial fibrosis, not replacement fibrosis. But we also measure it throughout the LV as well, especially in cases of suspected amyloid. So we do it in both. We do both. We do it in both ways.
All right, that's going to conclude our session. Boy, the hour goes fast when you're talking about a complicated topic and a fun one. So thank you both for joining us, Dr. Parwani, Dr. Kramer. Thank you for joining us and really highlighting some of the complexities, but the fun that goes into hypertrophic cardiomyopathy. Thank you both for coming today.
Thanks for having me. It's my pleasure.
Thank you.